Leica asked us to talk a little bit about our experience using our Veo and MyVeo. And me and Kyle, we work together at the Ohio State University. Partners now for a couple years, right, Kyle? And it's a pleasure for us and honor to be here and show a little bit of our experience. So Kyle is going to start showing some of the aspects of the technology, some of the concepts, and then I'll come back and show my perspective using the microscope. So thanks for being here. Kyle, go ahead.
So just to get started, this is our team. I think many of you recognize, obviously, Dr. Prevedello, Dr. Cranial, and this is the rest of the skull-based team. Right now, we have Joseph Lee, who's our rhinology fellow, and Dean Karras. We'll be going back to Northwestern for a faculty position. And besides just Dr. Prevedello and myself, we also have a head and neck team, and they enable us to do these really complex surgeries, the otology team as well. And they also use the Leica microscope. So some of the feedback that we are sharing with you is also their experience with their complex free flaps and otologic procedures. So, we have a huge team that enables us to do these procedures safely for our patients. And it's more than just Dr. Prevedello and myself. And we're really appreciative of having all of these people to support and work with us. So we'll just start off a little bit talking about the microscope itself. This is independent of the MyVeo. So this is the MyVeo 8, which is the latest iteration of the Leica microscope. And we just wanted to highlight some of the features that make this unique and special for us and have worked really well for our team doing the types of surgeries that we do. So I'll just start from the corner. So after draping, a lot of times, as many of you know, the microscopes become unbalanced. So there's an auto balance feature that allows us to quickly rebalance the microscope, which seems small, but that small frustration can be addressed quite easily with this microscope. Really important, and we'll talk about this a little bit more, and I think Leica's engineers who are here could probably give an even better description, is the fusion optics technology, which uses two separate lenses, one that's focused on high resolution and one that's focused on depth of field. So no longer do you have to sacrifice depth of field for high resolution when you're zoomed way in. You can have high resolution and high depth of field, allowing for it easier to bring in instruments in and out of the field and quickly recognize them, and they'll be in focus for a longer period of time while they're being brought in and out at different depths. The newer microscope also has an extended working distance to allow for you to operate at whatever's comfortable for you. This is especially pertinent for people putting in hardware, but also for Dr. Prevedello and myself, sometimes with patients in complex positions, sitting position, etc. He'll show you some videos on that as well. The other piece that we've really appreciated is the optics for the observer are by far the best quality we've seen for any microscope. It's 3D for the assistant if you're face-to-face, and it's kind of what we call semi-stereo, so semi-3D for the observer if they're on the side. And then Dr. Prevedello will talk more about the adjustable handpieces to achieve really complex angles that allow us to do procedures that would be much harder with traditional microscopes. For me, really important is the adjunct hardware, mouthpiece and the foot pedal, both of which I utilize. And then really interesting and special about the image that's created is a digital image with AR injection. And so that's a huge component of this, is the ability to augment reality with the microscope view. So fusion optics, like I said, I would follow up with the Leica team and engineering team, which was present, if you have any further questions. But basically, it utilizes two separate lenses, one that focuses on high res and one that focuses on depth of field, and allows your brain to fuse together those two images to make a perfect image in your head, but one that allows you to work with a greater depth of field and high resolution at the same time, kind of beyond the laws of simple physics. The different configurations, which Dr. Prevedello will talk about some more through some cases. And then the digital imaging aspect, where you're able to inject and project images, not just from the microscope, but also from other adjunct devices, such as navigation and the Glow 800, where they can project the ICG directly onto a live white light image, and the endoscope, which we use regularly. Here's just an example of the Glow 800 in a case that I performed recently, just kind of showing the difference between this and the traditional ICG imaging. So here you can see the black and white. It's hard to differentiate different vessels. What are the perforators? What am I looking at? But here with the Glow 800, with the augmented reality, it projects this on top of the digital image, allowing you to see both the normal anatomy that you're used to seeing through a microscope, plus the overlay of the ICG dye. You can integrate the endoscope to look directly through the microscope with the endoscope, so you can pass it into the field safely, switch between the view, and look at the endoscopic view. And you can integrate navigation directly into the oculars as well. So we found that it's really helpful for education and ergonomics, and I think Dr. Prevedello will talk to you some more about all of this through some cases.
Yeah, so I'm gonna show some of our experience here. Thanks, Kyle. I think that was great showing the what it can do, right? So this is just to show, like, this is that case, lateral position. This is a patient, a redo case, was hard for a trigeminal neuralgia. And you can see here, I'm just gonna go quickly through these cases, but the idea is difficult to represent here because this is in 3D. And the fact that you can get 3D in a like larger depth of field, like Kyle pointed out, like it's difficult to show in 2D here to you, but you can tell that in the case as well. So this is our patient that I did surgery and microvascular decompression, and she did well without pain for about a year, and then it started having pain again. So I did went back there, and these are difficult cases, difficult to see the anatomy. But what I'm convinced in this case, just as a little parenthesis here, like I found these little veins there that I decided to take, and some of these previous Teflon plagias touching the entry zone of the trigeminal. So I think that's something important for hemifacial spasm and also for trigeminal neuralgia. See, this is the Teflon that was touching the entry zone, and I worked on that, and I took that Teflon away, keeping the trigeminal nerve just free of anything touching it. I think this is something that Dr. Fukushima used to say, like this entry zone, if you put it too much there, you move the vessel away, you may still have hemifacial spasm and trigeminal neuralgia. And I think I'm still in a learning curve of this. So now when I do a fresh case, I try to avoid having that anything touching the entry zone there. So here's the final view. This is just to give you an idea, like hopefully, you know, like you can try yourself and see the advantages of 3D. So this is another example using the Leica with these characteristics. This is the hemifacial spasm case, lateral position. So this is very good with this microscope. Like I said, you adjust your handle and you can go down. This is a fresh case, so it doesn't have all that the scar of the abnormal tissue. Here you see the 11th cranial nerve there, and here dissecting the arachnoid. It's hard to tell, but you see there is a very large depth field that is in focus, and these are dissecting the arachnoid, finding the vessel touching the entry zone here on the case of a hemifacial spasm. 9 and 10 there, dissecting. And here adding the endoscope, and that's like Kyle said, like this you can integrate on the view. We don't have a way to show here, but I have an angle endoscope crossing above 9, and that way I see the entry zone of 7 there, and then I use both images of the endoscope and the microscope to then do the dissection and remove the artery away from the entry zone. So here moving that pica out of there, and putting the plagiate. This is another, like I said, try not to put it at the entry zone of 7 there. So just to move on here, so we decompress there just to show these are cases that we did. I think this is a good example to show other characteristics. So this patient with a tentorial meningioma. So for this, I did a supracerebellar infratentorial approach with the patient in seating position. And seating position is a challenge with any microscope. And here, what we were able to do with this microscope, you rotate 360 on the optics, and it's amazing how it kind of really becomes more comfortable, like you have, like that is available there. And here I want to talk a little bit of the MyVeo. So the MyVeo, look, I'm using the MyVeo here. I'm the assistant there, and I have my chief resident going supracerebellar. So with the MyVeo, I have 3D now. And remember what Kaya said is like pseudo 3D for the assistant. because for a seating position, I cannot use cross courts to get 3D there to assist. So with the 3D, this is amazing, because now I can assist with the 3D with the same view that the surgeon has. The key here, there's a little learning curve. It's not that fast because you're seeing the view of the surgeon. You're not in line. So I do a lot of endoscopy, so there's a need for a learning curve. For me, when I put my instruments in, like, if I awkward like that, quickly in my mind I adjust, but there's a learning curve. We're talking about this. Kai had some experience with that as well. It's not that easy. But once you get it, like, and you can assist in 3D, it's basically two surgeons operating at the same time. So I really enjoy there. You gotta just making sure that you position in a way that is not cumbersome in front of you there. And here's me, like I see, I'm not like looking down on the assistant. I'm using the MyVeo, seeing 3D and working parallel and doing the surgery. And then this is, see how I'm not kind of inclined it down because we were able to turn the optics. And then this is like us sitting on the main, going back and forth with the logistics here using MyVeo. And now then I combined, and then now I have MyVeo, if you see, and I'm standing very comfortable, like in a position that I can see 3D and working directly supracerebellar infratentorial there. So this is just to show some of the advantages of having. Now I'm in line with the microscope, so this is more intuitive, like in terms of dissecting, and it works very well. So this just to show that case quickly, since we have a short period of time here, but that's going supracerebellar infratentorial, and this we did that combination of the RVU microscope and MyVeo assistance. Sometimes you will see four hands here, is when we are using with the MyVeo kind of working parallel. But we exposed them in angioma, and this is a ultrasound. We actually went through, and it's very nice to see how thick is the depth as we debulk the tumor. And then ultrasonic aspirator and debulk them in angioma. And then once we got the tumor debulked, we went around and looking for the Rosenthal veins surrounding there. We found them, made it thinner progressively. We found the vein posterolaterally there. Very nice view. And some of these I'm standing with the MyVeo kind of working there. So that's allows a lot of comfortable dissection. So here's the post-op. We end up leaving just a little rim on the veins. You know, I thought that was prudent. We start getting some venous bleeding there, so we thought that was a good point to stop there. You know, we've done some other cases, but just to show like a middle fossa approach as well, coming extradurally for a small, coming extradurally here, and I'm going to go straight to the point where we go deeper there, stimulating facial. Drilling the canal from the top. Here exposing the dura of the roof of the internal acoustic canal, and drilling down, opening the dura soon, finding the facial nerve. And here's the canal itself. Then we opened up with a blade, rotating the dura. This is the schwannoma, now middle fossa, so nice view. And I would say that in general, really the depth of field and the quality of imaging is really good. And here we identify the facial nerve, as you can see on top of the tumor with the middle fossa. That's one of the issues there, not easy. But we rotate the facial away. Then this is with the sonopat, like an ultrasonic aspirator, debulking the tumor. And protecting the facial nerve. Here's dissecting the tumor, final dissection there. It's hard to talk about microscope without showing the cases, so we got to show a little bit of the cases. So, and then just to see the variety of cases that you can do with the microscope. So here, it's kind of the final dissection, going deep into the canal, protecting the facial nerve. Here's, sometimes they're stuck, we're coming from the top. You see the facial nerve now dissected. And this is the final dissection. This is why Kyle mentioned that we do this a lot with our otology team as well. They help us out on these cases by drilling, you know, they do the drilling and we do this dissection. And this is the final dissection of the tumor there. That's the post-op CT. with a complete resection of the tumor. Now, just to finish it up, I'm gonna show the use of the 800. This is an AVM. This is a collaboration here with Patrick Youssef, our vascular partner there. So for the AVM, so we use the ICG 800 with, you can see the projection of, in this case. So here's dissecting the vein from around the AVM, identifying the vessels. And then after dissecting here, the large vein, in one point, he used the ICG, as you can see here. So this, different than the other microscope, as you just have this projected, then you can actually project at the same time with the view that you have with the white light. So this is the regular ICG, but you can get this view here that Kyle showed in his meningioma case as well. But this shows like the AVM is already resected and the venous structures around are preserved, and you can see this all at the same time. You can see this on the MyVeo as well, and you know, allow for a lot of versatility. So the idea with this talk is to just show, you know, that you can basically do neurosurgery with a versatile like number of cases, multiple cases, and use this technology. So thank you so much. And I know that Dr. Landero has a question. So the question is if the focus system is the same or not. Yeah, so it's a good question. So in the MyVeo, there's a little adjustment that you can do, but you will contaminate yourself. So usually you adjust beforehand, make sure that is the same focus that is already there on the microscope. But because the image is digital, once you have this adjusted, then if the surgeon does a change on the focus on the microscope, you get the same adjustment on the MyVeo. So it goes together. It's very nice. Thank you so much.